Hello and welcome to another episode of the Power Panel. So before we get started, I wanted to mention that today's Power Panel is brought to you by Myos MD, the cutting-edge nutritional supplement designed to combat muscle loss and support healthier aging. Powered by Fortitropin, a natural bioactive compound which has been clinically tested to enhance muscle growth and reduced anabolic resistance. Myos MD is changing the way we think about muscle health. If you'd like to learn about Myos MD or Fortitropin, please go to myosmd.com to learn more. Alrighty, so let's hop into today's episode. We have an amazing guest, Dr. Maribeth Orr. So please, before we get started, if you could just give a little background on yourself and your area of expertise.
Thank you so much. First of all, I just want to say thank you so much to Myos MD and to you for inviting me to be on your show, your wonderful educational and fun event. I always appreciate things like this, and I love listening into all the experts that you have on. So I am Dr. Maribeth Orr. I am an obesity medicine specialist. I've been practicing medicine post-residency for, 23 years now. It doesn't feel like it's been that long. It's flown by. I spent the first 17 years of my career in family medicine, and now the past 4, going on almost 5 years, 100% obesity and metabolic health. So that's where I'm at.
Amazing. And so, I've gone through some of your previous content, and you've described obesity as a metabolic disease, not just a weight issue. So can you explain what exactly that means and how this changes your clinical approach?
Absolutely. Yeah, metabolic. I actually had to look up the definition of that at one point in my career. Well, what does that mean? Well, it's about energy production and energy balance. And the human body likes to find a state of homeostasis and energy. We have to have sources for energy storage, but then energy production and burning in order to live and nourish all of our tissues. So when we look at obesity as a disease state, it's really a state of energy production and storage dysfunction. So, and what does that come down to? It comes down to the heart of where energy is regulated and produced and burned in the mitochondria. So really, if we boil it down, the science behind obesity and then metabolic dysfunction behind it and that energy balance dysfunction, these are all mitochondrial diseases. So it's heart disease, type 2 diabetes, PCOS, dementia. We're finding out about dementia. It's a fundamental problem with energy regulation in the brain and in the heart. And so these metabolic diseases, that's what obesity is. I guess one of the beauties about obesity is that we can see it on the outside. It's visible. So in a way, it's like, okay, you actually have physical signs of it versus, other metabolic diseases. I mean, we've all seen somebody who's been diagnosed with dementia or type 2 diabetes or had a heart attack, but you can't necessarily see that. The other, fatty liver is another scary one. You can't necessarily see that, but with obesity, we have physical signs. So, that's how I look at obesity, is like, how can we improve this patient's energy regulation and their energy balance? And that's where I love talking about the muscle side and skeletal muscle, because it's such a key player here that often gets forgotten.
Absolutely. Yeah. And speaking about, things that are either forgotten or misconceptions, what are some of the biggest misconceptions that you encounter? This could be in both, working with patients, but also maybe working with your colleagues and other providers, and particularly how these misconceptions play a role in muscle and managing metabolic health.
Yes, that's a tough one. That question right there could just be like a whole 3 hours, right? So, I mean, I would say, as far as when I was talking about my background in family medicine for 17 years, I don't know that I really talked about muscle health ever with my patients. That's a problem. But it goes back to, kind of our training and our focus. And I think we kind of have a fundamental problem in medical education in America. In medical school, we learn, okay, here's anatomy, here's some physiology and what's supposed to happen and what's normal. And then you get thrown into residency. And in family medicine residency, I remember my first day was in the ICU, diabetic ketoacidosis, insulin drip. And like, oh, okay. So going back to your question, I think we're not really getting a lot of the education that we should for our healthcare providers in medical education. And also, when we talk about muscle and exercise, sometimes we put it in a category by itself of, oh, that's just for bodybuilders and athletes. Like, no, actually, it's for everybody. And it becomes a key when we're treating patients with metabolic dysfunction and with these chronic metabolic diseases. We can't just rely on medications to do the things that we need, to have fixed and improve. Muscle is a key endocrinologic organ, immunologic organ. It's got to be a key player there. So muscle goes far beyond just aesthetics as well. I mean, aesthetics, yeah, sure, that's nice, but we have to start thinking outside of just for athletes. We have to start applying muscle health and functionality and strength outside of just, CrossFit or bodybuilding. It's got to be for our 60-year-olds, our 70-year-olds. Like, what strength do they have?
Yes, definitely. And so I wanted to ask you, in your practice, how do you see muscle mass influencing insulin sensitivity, glucose control, and long-term weight maintenance? And I'm mainly thinking about this because you just mentioned, muscle has so much to do with endocrinology, and that's also something we don't hear about that often, is that connection.
Yeah, it's one of the, absolutely. Sometimes I like to trick my patients. I say, what is the largest organ in the human body? And, everybody says skin. Skin's the largest organ. Like, nope, it's actually muscle. So when you break it down by mass, muscle is the biggest, most active endocrinologic organ that we have. So when we put that into play, when we're looking at metabolic dysfunction and the drivers of that, the physiologic dysfunction, insulin resistance, inflammation, microbiome disruption, muscle plays a key player. Exercise, and when muscle contractions, and when we see muscle contractions, there's a whole cascade of biological, biochemical events that take place that influence other systems of the body. So myokines, cytokines, exerkines. I love that term, exerkines. I'm still learning about all this too. So it's fun to talk about it, and remind myself, I need to go back and read more about exerkines and myokines. But that crosstalk between muscle tissue and other systems of the body, and insulin and the hormones and everything. I mean, that's a whole nother 6-hour podcast, right? So muscle tissue becomes very important in that. And that's where I try to leverage the importance of healthy muscle tissue, not just mass or the amount, but the function and the strength when I'm talking to my patients. And it's good to be able to talk to patients about that too, and maybe take the whole you must exercise component out of it to talking about, let's just work on your function. Let's work on helping you feel better, because we know that when we have healthier muscle tissue and better function, we feel better too. And the cognitive effects and the mental effects. I mean, look at the wealth of knowledge that we have on exercise and improving muscle health, muscle strength, how it impacts every system of the body. So those, misconceptions that it's just for muscle, bodybuilders, is we gotta move away from that.
Definitely. And many people with obesity struggle with fatigue. You mentioned, cognitive impairment or cognitive, draining, and joint pain. So, all of these things together, are things that, people are not necessarily associating with obesity, but rather thinking about them as separate things. And so how do you help patients safely build strength, keeping all these, kind of multifaceted aspects in mind of obesity?
Yeah, tough. The implementation is really the biggest challenge there. We could sit and talk all day about the wealth of knowledge and the studies and the proven data that we have on exercise and its benefits, but translating that into patient care and helping our patients get there is a whole different ball game. So that's one of the nuances, highly nuanced, when we're treating obesity and metabolic diseases. Highly individualized. It has to be precision for each individual patient. And I think the key there is also meeting every person where they're at and helping to explore what are their barriers, what are their obstacles, and being there to listen to that and help, dive into, okay, what does this person need today? What are they facing? So it's a huge challenge. I haven't figured it out yet. I don't know that any of us ever will. I think it's always going to be a learning process for anybody who's treating patients and active in that clinical space. Just all the nuances that we face. It's a daily challenge. So I think it's best when we're talking about movement and muscle health with our patients with obesity who have pain, who have that fatigue. We want to start with small bites and start with, okay, how can we help you feel better? How can we do small things, little things, and focus on the function? Maybe we're working on walking, from into the grocery store. I want to be able to walk through the grocery store and not be tired. I don't want to be out of breath, or lifting the laundry basket. Or I know a big one that I like to focus on too for myself is, what do I want to be like 10 years from now? I hope to be holding grandchildren in my hands someday, not now, but I want to hold grandchildren, be able to lift them up. I want to be invited on when my kids have kids, I want to be invited on their vacations. So breaking it down and finding out, from each patient, what can they do now? What are they open to do? What's their goal? What's their focus? And then how can we help them get there? And mostly focusing on function versus, I want to increase my VO2 max. Well, yes, we want that, but how do we get there? How can we start with just small exercise snacks? That's a whole nother subject we could talk about for a good hour or so. Exercise snacks, great data there.
Wait, can you talk a little bit more about exercise snacks, like while we're on the topic?
Oh yeah, absolutely. I love that. I have a whole little handout that I can give my patients when we're talking about that, because absolutely, I get it. It's hard to make time or to find time for that 20-minute workout, 30-minute workout. I don't have an hour to spend in the gym. But do you have even just 2 minutes or 5 minutes or even just 1 minute if we really have to get down to the bare bones? Do you have 1 minute to stand up? Like, this is what I do. I mean, like, I'll throw what I do in between patients. Sometimes when I'm seeing patients throughout the day, I got 60 seconds. How many squats can I do in 60 seconds? Okay, I just got 1 minute of activity. I can probably knock out, depending on my depth. If I'm going for full depth, I can probably do a good 15 to 20 body weight squats in 1 minute. And if I do that 3 more times throughout the day and I get 4 bouts of exercise, 1 minute each, there are studies that support, hey, there are benefits to that. You get muscle contractions, you get those extra-kines, those myokines, you get improvement in your cognitive function too. You think clearer. So go for some exercise snacks. I get it. I mean, it's hard. I try to make 1 hour for that gym every single day. It's tough. We got track meets, we got dance recitals, we got choir performances. I get it. It's tough. You got work. They got that.
Absolutely. Yeah. And didn't a new study come out recently that said, like, instead of working out or like only having that 60 minutes or that 30 minutes per day, it's actually better to space it out throughout the day and do the same amount, but rather just do it in chunks, or like in snacks, as you call it?
Yes. I think, data. I will have to look at that study. I've not seen that one, but yeah, it doesn't surprise me. So yes, it's so good that we have people in that space studying that exact concept and having the mind to, okay, what's my hypothesis? Can we make broken up bouts of exercise equal these long bouts of exercise? And maybe even it's better. Absolutely. Same thing. What do we know about protein intake? The human body's ability to stimulate muscle protein synthesis, 20 to 30 grams is kind of that where we're at. But if we go too much more than that, the body has a hard time incorporating all of it. So we always tell our patients with their protein intake, 20 to 30 grams spread out throughout the day. So same thing with exercise. That makes sense.
Definitely. And can you talk a little bit more about other impactful nutritional strategies? You started talking about protein. What else can patients incorporate when it comes to supporting, fat loss as well as preserving lean muscle?
Yeah. 2 words, real food. I mean, real food. One of the best things I learned when I started into obesity medicine, and my mentor, Dr. Courtney Younglove, she runs Heartland Weight Loss here in Kansas City. Big props to her. She's taught me everything that I know, by the way. So, and I keep learning from her. She's a wonderful colleague. So she said to me, food was meant to be food, not a collection of food-like substances. Like, wow, food was meant to be food. So that's one of the biggest levers that you can pull. And I talk about that with my patients, no matter what diet you choose or what nutritional approach you choose, whether it's vegan or carnivore or Mediterranean or pescatarian, what has to be at that foundation is real whole food, and trying to reduce our consumption as much as possible of ultra-processed foods. That is key. It's paramount. We have to play into our primitive DNA and how we were designed to be fueled. So that's the big takeaway. Whole food as much as possible. Now we live in an ultra-processed world, and that's 70% of the standard American diet is ultra-processed foods, added sugars, foods that have been through 25 machines. We're never going to be without them. It's near impossible to avoid them. But what we want to do is try to have a good foundation where the majority of what we are doing, and our foundation is whole food. And we don't have our foundation based on ultra-processed foods. That's a whole nother problem and a whole nother realm to try to dissect and to help our patients with. That's a really tough one. And if we go into more nutrition discussion, my goodness, there's a lot of emotion attached to that. Yikes.
Yeah, definitely. So shifting gears just a little bit, I would love to talk about, in preparation for our discussion, I found this, kind of phrase, sarcopenic obesity, which I haven't actually heard a lot about before our discussion today, and we haven't gotten to it yet. So I wanted to ask you, what is it? And why is it so critical to address, both the fat loss side and the muscle preservation side when working with, patients?
Yes, that's a wonderful topic. And I love it. I just came back from the Obesity Medicine National Conference, Obesity Medicine Association, the OMA National Conference in Washington, D.C. a few weeks ago. And there was a lot of discussion on this and some wonderful presentation about sarcopenic obesity. And we've got to start spreading that knowledge to our healthcare providers, our caregivers in this country, and even, us in the obesity medicine world. We've got to start talking about that, because, we're definitely, focusing on weight loss and fat mass loss. But while we're doing that, we've got to start talking about and having that focus on lean mass preservation and protection while we're working on healing the mitochondrial dysfunction and the energy balance and the metabolic dysfunction. So sarcopenic obesity is, they interplay. They're not siloed, they interplay. So we have a lack of lean mass or low lean mass, particularly skeletal muscle. That's what the, sarco and penia, the Latin for small muscle. And then fat mass, excess fat mass. So excess fat mass has all kinds of metabolic disruptors, that again, the biochemical disruption in there, and it plays into further reduction in lean mass. And as we lose lean mass and the endocrinologic benefits of skeletal muscle, that plays back into making the fat mass disease worse. So there's such a close interplay between there. So while we're treating obesity, in addition to monitoring weight loss, that's where that body composition and trying to make sure we're protecting that lean mass while somebody's in active weight loss and throughout their lifespan, to help reduce weight regain. So that should really be our focus too. While we're treating obesity, we got to be thinking long-term, because weight regain, it's on the list. That's how we're programmed. Again, our DNA, humans are programmed to not lose weight. Why? Primitive DNA. It was threatening to our ancestors. So there's all these adaptations when we start to lose weight to protect against further weight loss. So that's where we want to try to mitigate those responses. So the reduced resting metabolic rate. How do we do that? Protecting muscle mass is how we do that. So sarcopenic obesity, yikes, there's lots of metabolic dysfunction happening there. So we want to make sure we're focusing on both. And probably, I would say, most of the time when we're seeing patients with severe obesity, they've also got sarcopenia in there. There's something going on, sarcopenia.
Can you also talk about, since you brought up the conference that you recently went to, can you talk about some of the other key findings or trends in the discussion? I'm very interested, especially, as someone who's an expert in the field, would love to hear your perspective.
Oh, yes. Wow. Okay. Yeah. So trends as far as body composition, I think we're leaning towards that trend of measuring body composition and monitoring it. And in addition to not only body composition and categorizing, okay, where is the excess fat mass? So, the 3 depots for fat mass, subcutaneous, visceral, and then intramuscular or intracellular. So trying to find out where is the fat mass. We know that subcutaneous is the least fat deposition is the least dangerous. Visceral fat is more dangerous, but then that intracellular fat, i.e. fatty liver disease, fat deposition in muscle cells themselves, that's that high abnormality, and that's the dangerous metabolic disease. That's where the danger is in metabolic dysfunction. So the visceral fat and the intracellular fat. So measuring that and getting, if we can get insurance companies to cover measuring of body composition and where the fat mass is, that would be helpful, wouldn't it? But in addition, another trend is there's talk about making grip strength like that 5th vital sign. So yeah, so while we're working on weight loss and improving metabolic health, in addition to preserving lean mass, we want to make sure that we're also helping with that strength component and the functionality and the quality of the muscle tissue that we're trying to protect. So not just the mass itself, but the quality. And that's where something as simple as a grip strength, gosh, where are we at? If somebody's lost 30 pounds, what happened to their grip strength? We want to try to keep tabs on that so that we're helping protect them into their future and protect into, those chronic diseases, into type 2 diabetes, dementia, all the things that, we talk about with that too. So that is very interesting to me. I don't think a lot of us are there yet in our obesity practices, but I love where it's going. It's like, okay, let's start measuring these things or measure actual functional fitness. How long does it take you to stand up out of a chair, or the get up and go test, or the, walk a certain distance, what's the speed? So I think trying to get some of those measurements would be helpful. There's definitely clinics that are working on that and are a little forward thinking, but yeah, that's some of the stuff that we all should be looking at. A lot of the talk. I love the grip strength one. I think that's cool. That's cheap and easy to do.
Absolutely. And I'm also thinking some of the things you're talking about, it almost sounds like a blend of functional movement and thinking about daily life activities and quality of life versus, something that is a bit more performance based. So I like that shift as well.
Yeah, me too. Yeah. I like to sometimes listen to the, the Centenarian Decathlon, and as we age, or the octogenarian Olympics. It's like, okay, what do you want that to look like for you? That's one of Dr. Peter Attia's things that he talks about, and I love that. And I've gone through and sat with my patients at times when we're trying to remove obstacles and barriers and help the mind shift away from I have to exercise to, well, what are my goals for my future? What would make me happy in my future? What's going to contribute to my quality of life? I've done worksheets before. Like, we're going to write down 10 things that you want to do when you turn 70, when you turn 80. What do you want your 100 years old self to look like? So yeah, shifting that towards that functionality and like, what's going to make you happy? That's all what it boils down to too. We're all here just to be happy and thrive. That's another one of my favorite buzzwords that I learned in obesity medicine and in treating metabolic health. And it's like, we're all here to help our patients thrive.
Absolutely. Yeah. So as we wrap up, we'd like to thank Dr. Orr for being our guest today. That was maybe one of the quickest sessions ever that just flew by. So thank you so much to Dr. Orr for being here, and to MyosMD for sponsoring today's Power Panel. Fueled by the revolutionary proprietary ingredient Fortitropin, MyosMD is trusted by healthcare providers nationwide to deliver real results backed by science. So if you'd like to learn more about MyosMD or Fortitropin, you can go to myosmd.com. We also have all of our recordings up on YouTube, so we'll have this one up very soon, as well as, so you can find that there. And we have a bunch of other really great information on the website. So please do not hesitate to reach out to either of us if you have any questions. So Dr. Orr, how can listeners learn more about you or, get in contact with you?
Oh, thank you so much. Yeah, I'm on LinkedIn. That's fun. I think Maribeth Orr on LinkedIn, Instagram, kind of my alter ego on Instagram. I like to share a lot of my own personal athletic endeavors on Instagram. So I talk a lot about triathlon, and that's kind of my bread and butter activity. I love it. That's what makes me thrive. Weightlifting, powerlifting, I love it. I have just an appreciation for all kinds of sports. So LinkedIn, Instagram, I'm on Facebook too, maybe a little less, kind of gotten away from that one a bit. TikTok, those are the fun places. I don't have a website yet. Maybe I'll get there. I'm too busy riding my bike right now, though, to develop a website.
That's amazing. And I think that, like, you even just talking about these like exercises that make you excited and that make you, want to thrive and get on that path, I think is inspirational for people who are listening, who are also trying to find, what are the activities or the things that they look forward to outside of work that can help them get on the same sort of path.
Oh, good. I hope so. That nothing fuels me more than to hear somebody say that they were inspired. I will say, in my history, we all started our own ground zero. I had a very much a ground zero in my own personal life, and that's what led me into this area of my professional life. So it's good to try to meet my patients where they're at and where they're starting, what their ground zero was. Briefly, I started not being able to walk a lap around a track, so 400 meters, without being out of breath. And I completed my 5th Ironman last October, and actually my 10th 70.3 Ironman just last week. So it's amazing. Doable. It's doable. So whatever you want to do, that doesn't mean that everybody has to reach for craziness, but reach for something that makes you happy.
All right. Well, thank you so much. I love to end on that note. And yeah, if you'd like to reach out to anyone who's listening to the recording, please do not hesitate to do so. All righty. Well, thank you so much. And until next time. All righty.
Bye. Bye-bye. Thank you.